you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
You know, God is wrist pain by doing over-aggressive high fives to his buddies.
Hey, Ultrasound Podcast listeners, Mike and Matt back with the Ultrasound Podcast. We're going to do a podcast today on a lecture that Matt and I gave at the St. Luke's Regional Ultrasound Symposium. Now, this lecture is on two things. One, and probably the most important, is the future of medical education, but also we're going to try to throw in some lung ultrasound there to try to get some good clinical education.
Behold the future of medical education. That's somewhat of a grandiose title. We understand that. And so the first question to get out of the way is, what qualifies us to be telling you what the future of education is? Are we really qualified to talk to you about this? And the answer is a very simple no. You know, we're not one of the heroes of ultrasound who kind of founded it like Liechtenstein. We don't have all the answers, but we do have our opinions. Just to clarify, we know opinion isn't exactly evidence, but this isn't just opinion, it's, strong opinion? Yeah, that's it, strong opinion. So we're going to give you our very strong opinion on where we're going and where we should go with medical education, how we think we can do this better. So to start off, where are we? So this doesn't work, okay? You know, it may have worked when this was the only way for us to actually disseminate knowledge to a learner, to stand in front of them and lecture, but we've moved beyond this, or we should have moved beyond this by now. And I understand the thought. The thought was, you know what, you combine knowledge with experience, whatever that experience is as a training physician, and then you get this, you get a very clinically competent, a great physician when you combine the two. But we really believe that we have to abandon the artificial barrier between knowledge and experience.
That's pretty awesome, Matt. You know, I've never actually quoted myself in my own lecture. It takes some real cojones to do that.
Someday, Mike, you'll get to that point where you can quote yourself in real time. And Teal, why don't you be quiet and listen? Of course, I had to act tough around Mike, but the truth is, I've always dreamed of someone quoting me someday. But the dream has died, so I've now resorted to quoting myself. Sad, I know. Look for more of me quoting me in the future. So this is what we actually call just-in-case learning. Teaching someone something, cramming a bunch of knowledge into your head in case you ever need it. And like I said, this is all we had at one point. We tried to remember as much as we could to hopefully have a positive impact when we had a patient that came in that needed the information that we had crammed in there, and we hoped that it was still there. What we think is a much better way of doing it, and what we want to focus on, is just-in-time learning. If you can learn at the bedside when you need the information, that's going to be much better. You're going to benefit your patients, and you're going to remember the information much better. Just let me give you an example. I recently gave a lecture to our medical students on trauma ultrasound, and I spent about 10 minutes on pneumothorax, and I thought they were paying attention. I thought they were really getting it. But that same day I had a shift, and a patient came in. I was working with one of the medical students, and the guy came in who had a big fall. He was in quite a bit of distress. He was stable, but we really were worried about pneumothorax. So I asked the student, all right, give me the answer. Go ahead and scan his lungs. And she couldn't remember how to. So I had failed. I really thought she was getting it, but she obviously hadn't. Instead of me just doing it, I actually showed her right there. We have an iPad attached to the ultrasound machine. I showed her what the normal and abnormal sliding is, gave her a quick 60-second tutorial, then handed her the probe, and she got this image. It was clearly no sliding. The right side there was sliding, so we popped a chest tube in this patient's left side, and he did fine. So that 60 seconds of teaching at the bedside, she is definitely going to remember that much better than those 10 minutes of education that she had in the classroom. Even though she was paying attention, it's just a very different environment. Her brain is set up to remember this and to be able to form those permanent neural connections that she needs to make this a memory, a permanent memory. So we're not saying this is evil and that we should definitely do away with the lecture. We believe that the lecture is an important part of medical education in extreme moderation. We do way too much of it. But in the meantime, while we're moving to more just-in-time learning, how can we make this just-in-case learning, this lecture, a little better and a little more efficacious? Well, we believe very strongly that it doesn't matter what you learn. It does matter what you remember. So how do we get our learners to remember what we're teaching them when we lecture to them? Well, one way to imprint on people's long-term memory and help them remember is to have their heroes teach them. We tried this at Castlefest by having Weingart, Noble, Stone, Reed, and Blyvis teach instead of us teaching the whole course. I remember what those guys say because they're brilliant and my ultrasound heroes. But what if you're Mike and I? How do common folk like us get people to remember what we teach them? Well, there's a few tricks. Number one that we kind of like sometimes is laughter. Now, there's obviously a problem with this. We're all professionals. We want to be taken seriously when we talk about medical education. And if we put a bunch of really embarrassing pictures of ourselves up there, then we're not going to be taken seriously. So how do we strike that balance of being taken seriously, being professionals, but getting people to laugh? We know that laughter is an enormously helpful tool, because if someone is laughing, they're definitely engaged. They're paying attention. And if they're not paying attention, then the laughter around them cues them in to listen. Nobody wants to miss a good joke. So I've come up with a pretty good solution. I've got a partner that I simply humiliate. Use him. Right? Now it takes a little bit of skill with Photoshop, the ability to edit some text over a picture, and boom. At the expense of someone else, you can get some good laughter and not worry about them having an image of you that's inappropriate. Now, this picture really isn't fair. It's in reference to the fact that Mike is from South Carolina, but I should explain. Don't get grossed out. This isn't really his sister. It's his cousin. They're really close. But you shouldn't have to make people laugh to get them to remember, okay? I mean, it's great to do. We use this all the time. But there are other ways to get people to remember things that you teach them. One is with adrenaline. You know, we work in an environment as emergency medicine doctors where we see crazy stuff. You know, and we remember how to take care of these patients after you've seen them once or twice, because it's such a vivid memory. However, we're not going to have that sort of level of adrenaline and catecholamine surge when we're getting a lecture. So you can artificially create that. Simulation. We're not going to talk a lot about simulation because everyone's in a simulation. Everybody's talking about it. But there are other ways. Point to your audience member and ask them questions. That may not be the kindest way to lecture, but it's definitely going to get people to remember. When their heart rate goes up as you're pointing at them, asking them a question, whether they get it right or wrong, they're going to remember the right answer next time you ask them. You can also use some other tricks. Asynchronous learning. Mike recently at the University of Utah, they wanted to learn about delayed sequence intubation, but instead of just giving a lecture on it, they collated all the podcast material and the written material they could find on it, and everyone looked at it ahead of time, and then they had a big discussion with actual experts in the field. And Scott Weingart even joined the discussion via Google Hangout. Now, knowing that these experts would be involved in the discussion gave the learners a real incentive to learn it ahead of time. This flipping the classroom and getting the content ahead of time to read, watch, and listen allows some really great active learning to take place via discussion when the group comes together. Recently at my university, we had a debate. So we wanted to look at the question, do you really have to do routine LP after CT for subarachnoid hemorrhage if it's been less than 6 hours from time of presentation? So we got all the podcasts, everybody listened to all of the materials, and I sent them the major articles written on this. It was quite a bit of material. Then the residents divided up into teams and debated this, and they were super engaged because they don't want to be humiliated. So they really studied the material, they learned it really well, and I'm pretty sure they're going to remember what they learned. When you're talking about ultrasound is a perfect medium to do some hands-on learning while you're lecturing. For example, at CastleFest, we stream the lecture live into the other rooms so that you can actually watch Blivus, Weingart, Noble, Stone talking about echo or nerve blocks. And you can be scanning the other room trying to get a cardiac output yourself or trying to find a certain nerve that they're talking about. And then if you can't find it, you can live tweet in a question and they'll stop during their lecture and answer you. So you get real-time feedback. It keeps the lecturer actually honest and forces them to be very clear with what they're saying. But what we really want to focus on is just-in-time learning. That's really where we think the money is. Now, some of you are probably thinking, isn't that just what residency is? You know, you're seeing patients, your attendings are teaching you at the bedside in real time, and that's true. And if you've got incredible attendings, like Dr. Noble, Dr. Lewis, then that's wonderful for you. But what if Mike or I are your attendings? Well, luckily for you, you've got basically all of the world's knowledge in your pocket. Let me give you an example of what I mean. I recently had a case, a patient came in VFib arrest. We shocked them. They didn't get better. We went down the algorithm, shock, epi. And in my experience, they usually either get better or they deteriorate into asystole. However, this patient didn't. So this went on for some time. About 30 minutes in, I started getting kind of frustrated, thinking, what else could we be doing? We tried a few of the kind of standard things for refractory VFib, but I really wanted to look it up. I wanted to pull my phone out and actually just Google this, let's see what else I could find about refractory VFib. But I was kind of embarrassed as the attending to do this. I didn't want to look like I didn't know what I was doing. But I finally decided that my pride probably wasn't as important as this patient. So I pulled my iPhone out, and with the resident, we looked up refractory VFib. We found several things that we hadn't done that we went ahead and tried. And this was kind of a profound moment for me because I had heard some people talk about this concept of possibly in the world we live in now, with the micro-learning environments that we can create for ourselves, is knowledge actually irrelevant now? And I don't believe it is irrelevant. But when I first heard about this concept of knowledge being irrelevant, this is the exact scenario that came to my mind to refute that concept. When a patient comes in coding, you can't be looking things up. but I actually did in this patient, and actually changed my management a little bit. So I don't think that knowledge is irrelevant, but I do think that just-in-time learning is definitely king. Even in a situation like this, I could apply these concepts at least a little bit to change practice and to make a difference. And I'm going to remember those refractory VFib treatments now, the ones that I didn't before. So how do we do this? How do we create these micro-learning environments and facilitate this for our residents? Look, we're going to give you a few examples of how we do this. Both Mike and I have iPads attached to our ultrasound machines, and you can look at a patient in real time who you think may have a pneumonia and read the chapter in the iBook on pneumonia. Look at the images and see, is this really pneumonia? Is that what I'm seeing here? You can also look at 1-minute ultrasound, which we have installed on these iPads. And you're looking at someone's heart, you can look at how to scan for cardiac output. You can turn the volume off and play it while you're scanning. The patient doesn't know, but you're actually scanning along with our little tutorial on how to do it. And then we've also loaded up other procedures that it's just nice to have a couple of visual cues at the bedside to remind you exactly what you're doing, just to make it possibly a little bit safer for the patient and help you remember a little better the next time. Mike, you had a pretty incredible case the other day that just showed the power of just-in-time learning as well. You want to tell us a little bit about that?
Yeah, thanks, Matt. So this is a case that I had recently in the emergency department. So this is a real-life case. This is not made up.
Actually, Mike, I changed my mind. I mean, I'm dying to hear your case, but we're going to save that for next time, part 2. Instead, we're going to put our money where our mouth is. It's one thing to blab on about how to do it better, but we want to actually try this with you. Remember, we already told you that we're going to stream CastleFest free. So here's what we suggest. Find a friend, someone who likes gel and an ultrasound machine. Then watch CastleFest with this friend and scan each other and practice in real time what you're being taught by Weingart, Noble, Stone, Blibus, and Reed. And like we mentioned earlier, tweet your questions if you're not getting it. Follow us at UltrasoundPod on Twitter and tweet to us and use the hashtag CF2013. The CF stands for CastleFest, obviously. Your question will be displayed on a big screen in real time at the conference, and we and others will be monitoring your questions in real time and answering them. And if it's complicated and we need to stop the lecture for clarification in real time, we will. You can watch the whole thing as a Google Hangout. Just follow us on Google+. We're simply Ultrasound Podcast on Google+. And we'll also post links on Ultrasound Podcast website, and we'll tweet out links. We'll try to make it easy for you. It's going to be an amazing educational experience, especially if you join us. And lastly, cut us a little slack. We're going to have multiple cameras and feeds and lots of technology going on at the castle, so we're slightly concerned we're going to outstrip the internet capabilities available there, even though we've had it upgraded to the max. But we're going to try it. Join us, 2 days away. And then we'll talk to you in a few weeks with part 2 of the future of medical education. If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.